Agora vamos dar continuidade na nossa agenda com o Dr. Thomas Coates, do Children's Hospital de Los Angeles, Estados Unidos, que vai falar sobre manejo da terapia quelante de ferro. Então, Dr. Coates, please. Deixa eu chamar ele, que acho que ele está distraído.
Thank you. Sorry, I wasn't paying attention, which my wife tells me I do all the time. Don't pay attention. Things are the same in Brazil as they are in the United States, apparently, with wives and husbands. I'm very, very honored and pleased to have been invited to speak here. Especially to the patients. I'm going to listen here if I can. Okay. I don't understand Portuguese, but if I talk too fast, I can tell if she gets behind. Okay. Okay. So, I'm going to talk about treatment of iron overload, but I want to give you a little bit of background first. And Dr. Trichta already introduced a lot of the things I want to talk about. So hopefully these two talks will fit together a little bit. Okay. So why do we transfuse patients with thalassemia in the first place? And a lot of times people think it's to treat the anemia so you feel better. But actually what's happening is because you can't make blood efficiently, your bone marrow is working extra hard. It's very much like if you're trying to run on ice. You work and you run, but you don't get any place. And what happens when you do this is the bone marrow gets bigger. It increases in size inside your bones. And this causes the bones to get thin because the bone marrow is expanding. So the reason that we give transfusions is to trick the body into thinking that you have enough blood, and that turns off the bone marrow. So that's the most important thing. And I say that because sometimes doctors think that you should withhold transfusion to protect against iron. But that makes things worse. It makes the bones get more thin, makes the liver and the spleen get big. So what we want to do is balance things and give enough transfusion to turn off the bone marrow, and then give enough chelation to get rid of all the iron. And we can do that. I can tell you that in our practice in Los Angeles, we have about 120 patients that are on transfusions. And probably a third of them have normal liver irons. By that I mean an iron of 1.5, liver iron of 1.5, ferritins of 50 to 150. So it can be done. It takes a lot of nagging on the part of my nurse, who is wonderful, and a lot of work on the part of the patients. It's all on you and the parents. Of course, this causes severe iron overload. But again, we want to control that with chelators, not by stopping transfusion. Even if you aren't transfused a lot, as Dr. Trickta mentioned, your body thinks if you're anemic, the way to correct it is by increasing iron absorption. So you will increase iron absorption, and you get iron overloaded anyway. So this is an X-ray of the hand, a normal X-ray. You see how nice and white the bones are here? Okay. This is the hand of a child with thalassemia. You see how the bones are all swollen and the inside is all moth-eaten? So this is what we're trying to prevent with the transfusions. And then you can see this child. We don't see kids like this anymore, fortunately. With a huge spleen and a huge liver. So the bone marrow is now growing in the spleen and the liver to try to keep up with production of red cells. So if you're getting enough transfusion, your liver and your spleen will not be enlarged at all. So you've already seen this slide 1,000 times. Each unit of blood has 250 milligrams of iron. And as Dr. Trickta said, you have no way to get rid of it without chelation. So in your body, you have a chemical called transferrin. How do you say iron in Portuguese? Ferro, okay, all right. So all these medical words that we use are complicated words based on Latin. So we speak in Latin to keep you confused, so we can charge you more money. Okay. Transferrin means the chemical that transports iron. Simple, right? Okay. About 30% of transferrin contains iron normally. So it's like a sponge that's dry. When you have too much iron, just like you see the water's leaking out of this sponge, you have iron that goes into the blood. When iron is bound to transferrin, it isn't dangerous. But when iron is free in the blood like this, it actually burns the tissue, like the picture of the rusting chain that Dr. Trickta showed you. It's only this kind of iron that goes into the pituitary gland. We're going to talk more about this in a little later. The pituitary is the main gland that controls all the glands in your body. Okay. Of course, it goes into the heart, the pancreas that regulates sugar, and the gonads, well, we know what they do. Okay. All right. So, when you chelate your medicine, the chelation medicines bind to that free iron immediately. And they immediately protect from the damage that's done by that, even though the iron hasn't been removed yet. So that's really the first role of the chelation medicine, is to protect you from the toxicity of the free iron. Okay. Whoops, wrong button. They also prevent that free iron from going into the heart and into the endocrine organs. So even if you haven't removed the iron yet, those medicines protect you in a couple of different ways just by circulating in your blood all the time. After a while, the long-term effect is it removes iron from all the places where it's stored in your liver and in the organs. The iron goes out of different organs at different speeds. So if you're taking full doses of chelation, one medicine or multiple medicines, you can reduce the amount of iron in your liver by 50% in 4 to 6 months. So if your liver iron is 15, 6 months later it can be down to 7. And 6 months later, down to 3.5. So it drops by 50% each time. So you can see if your liver iron was 15, it would take about 1.5 years to get your liver iron down to normal. The heart takes 17 months for the amount of iron to go down by 50%, much longer. The pancreas and the endocrine organs are in between. So if that free iron is high in your blood and you don't take your chelator for a couple of days, that free iron will start to go right back into your heart and right back into your pancreas. That's why it's important to have some chelator all the time. You know, as Dr. Trickta said, iron doesn't take any holidays. I like that phrase. So you can't take any holidays with your chelation. Sorry. But if you keep your iron normal, you will have no side effects. You will go through puberty, you will be fertile, you'll have no cardiac problems. I have some patients, some children that are in their 40s and 50s who have been well chelated all their life and have zero problems. Well, they're a little crazy from taking the Desferal all the time, but we'll smart. Okay. So, the red line here is the toxic form of iron. And this is time, you can see. The blue line is the blood level of Desferal, the chelator that you infuse under your skin. Some of the younger patients here might luckily not know about that. You can see as soon as the Desferal level goes up, the toxic iron goes down to 0 immediately. And as long as the chelator level is high, the toxic level is low. And the minute you stop the chelator, the toxic iron comes back up again. The same pattern is seen with Deferoprone, with Feriprox, and also with Exjade. The shape of the curve is different because the blood level are different at different times, but the concept is the same. So it's really important that you have chelators circulating in your blood all the time to protect yourself from the damage due to iron. So when I think of organ toxicity, organ damage, it's related to how much iron is in the organ and how long it's there. So a small amount of iron over 20 years can cause damage. So it's the level of iron times the amount of time. There are some other things. We'll talk about environmental factors like vitamin levels. And there's genetic things. And different people have different genetic things that make them more or less susceptible to the damage. We don't understand those very well. But it usually takes several years to get organ damage, even if the level is high. But removing that toxic iron from the blood can make heart failure and heart rhythm problems better, literally within days, very short period of time. Even though the iron level in the heart may be very high. So again, it's this iron that's circulating that's causing a lot of the damage. So even though the iron in your heart may take 17 months to go down by 50%, the heart failure and the rhythm disturbance can go within days to weeks. If you continue the chelator, you'll ultimately get the iron out of the heart as well. Okay? We can always reverse the heart damage as long as we get the patient in enough time. What's enough time? So I get a call with a thalassemia patient that is in an intensive care unit, very sick, near death. If we can keep them alive for 3 or 4 days until the chelators begin to work, they'll get better. Okay? Shorter than that, oh, it's pretty tough sometimes. That may sound frightening, but to me it's very, very hopeful. You're being followed by doctors here that know about these things. So this shouldn't really happen. We haven't lost a patient in, I can't remember the last, well, actually I do. I remember every patient. But many years. Okay. The endocrine organs are a different thing. They're not so predictable. Okay. What is good news and bad news? My expectation is that thalassemia patients will live almost normal life expectancy if their iron is controlled. When I started in medicine in the 1970s, half of the patients died by their 15th birthday. Now I expect them to live into their 60s and 70s. Because of the long time of exposure to iron, iron increases the risk of cancer. So this is the other reason that we want to control the iron perfectly when you're young. Because I don't want you to get these other complications when you're 50. As Dr. Piga said yesterday, that cancer is part of aging, of course. But iron plays a significant role, and if we can reduce that, we should do it. So here is a picture like Dr. Trickta showed. And here you can see that the iron in the liver is all black. The liver is very black, meaning it's filled with a ton of iron. This is a cut through the chest like this, and you're looking down from the top. So this is the muscle of the heart, and you see it's dark also. So normally when I tell one of my patients they have iron in their heart, they start to take their chelator. And you can see here in the next picture that the liver is light gray. The iron has come out. I told you that the liver clears quickly, but the heart is still black. So this is one of the reasons when we're managing patients, it's important to do the MRI so we can follow how the iron is going in all the different organs. I just put this slide in after the discussion this morning. This is iron levels in the pituitary gland. This is the gland in the middle of in the brain that controls all of your organs, endocrine organs, and controls when you go through puberty. Here's age, and this upper line here is what we say is 2 standard deviations above normal. If you're higher than that line, you're abnormal. Look at 5 years of age. These patients already have a lot of iron in their pituitary gland. So you load the pituitary gland very early. So I think this is why it's important to make sure we have good iron control very young. Now, there was a question a little bit earlier about a high ferritin in a baby. We do need to be very careful about interpreting ferritins in babies. Normally at 3 months of age in normal babies, the ferritin goes through the roof and it's not dangerous. So we worry about trying to control these things in really little kids. But I think as Dr. Tricht and I were talking to each other earlier, we need to begin to think about that more carefully. Precisely to protect against this damage. This picture in the red area, these are patients that have their pituitaries not working anymore because of the iron. This is iron on the pituitary gland, and this is the size of the pituitary gland. So as the pituitary gets exposed to iron, it gets burned and it shrinks in size and stops working. And you can see that there are some patients here who have small, anything below this line is a small pituitary, who have small pituitaries without much iron. We don't know this for sure. We need to do research on this. But I'm very worried that exposure to this free kind of iron is causing damage very early, even before the iron is actually detectable by MRI. You know, iron that's in ferritin is not dangerous. Ferritin is designed to protect you from the iron. The iron we measured by MRI also is not the dangerous form. It's very hard to measure the dangerous form of iron. Now, this is a test that we're doing at our institution as a research study. This is not routinely available in clinical stuff, so don't go running to your hematologist and ask for this. But just to address some of these questions about puberty this morning and the role of iron, there's a lot of things that we don't understand. But I think the answer is the earlier you can establish excellent iron control. And in my mind, and Dr. Tricht's mind, and a few of our, the way we think about these things now, we're not accepting any abnormal high iron. We want everybody to be normal. So this is my list of chelators. I'll make just a few comments here. Desferal has a very short half-life. That means when you inject it into somebody, half the drug is gone in 30 minutes. That's why you have to continually infuse it under the skin or intravenously all the time. Deferoprone or Feraprox lasts longer Every 3 to 4 hours is about the half-life, and you need to take that drug 3 times a day. This drug is really different than the other ones in that it's a small-sized molecule, and it goes inside the cells better. And it's very protective against the oxidative damage from the iron. It's the best medicine for protecting against damage. It's really the only medicine that relatively quickly corrects the contraction of the heart and makes it better if you have iron in the heart. It's also effective at removing iron from the body. And it's actually pretty well tolerated. We've switched, as soon as it became available in the United States, which was just a couple of years ago, moved most of our patients over to that, or a lot of them over to that, because they didn't complain of as much stomach trouble as people do with X-Jade. X-Jade has the longest half-life. So if you take it once a day, it's circulating for 24 hours. So it's good in that regard. But some patients tolerate it very well. Many patients, especially older patients, it gives them terrible stomach discomfort. One of the things that we do that actually improves the absorption is to give it twice a day. Take the same dose and split the dose. Give it every 12 hours. That improves the absorption and can decrease the side effects. And there's a new form that's been available. I don't know, is Jade New available here? Yeah. So Jade New is a pill form of X-Jade that you just take and swallow. And it's only been available for, I'm going to say, 6 months, maybe not even that long in the United States. And the initial reports from our patients is that it's much better in terms of its tolerance, of GI tolerance. As we'll talk about at the end, all of these are effective and good. All of the chelators have the same problem that none of the pharmacy companies have been able to solve yet. And that problem is they don't work if you don't take them. Okay? Dr. Trichta and the people at Apopharma are working very hard on this for a form of Ferroprox that they can beam into you on magnetic waves. But I'm sorry to say they're failing miserably. So you need to work with your doctor and talk about how to combine these things, these drugs, in a way that makes sense, that fits in with your lifestyle, and makes it possible for you to take them. Because again, I have to repeat, if you keep your iron under control, my expectation is your life expectancy will be normal. And there are a lot of very exciting things coming down for thalassemia. New medicines that make the thalassemia actually treat the thalassemia. Gene therapy for thalassemia. Patients have been treated already. And I feel it's my job and our job to keep the patients in perfect health so that when those things are available, you can take advantage of them. If you have diabetes, if you have heart failure, it doesn't matter. But if you have diabetes or cirrhosis of the liver or these severe problems, and we correct the thalassemia, the treatment for the thalassemia won't correct the diabetes, it won't correct the damage that was done by the iron, so you need to get it under control. So I think we've already talked about combination therapy, and we combine them to, as much as possible, make sense in terms of drug doses, but also so that you'll take them. There's really no good data on these combinations yet. And there probably never will be. So I think the main thing we need to make sure is that we use sense when we combine them together. And I don't really care what combination, in some fancy randomized study proves one combination is better than the next. The biggest problem with doing those kinds of studies, again, is that patients don't take the medicines. And we can't really tell whether they're doing better because they're taking them or whether they're doing better because the combination is better. But we do need to watch safety. We worry very much that combining these may increase the dangers, and so we need to watch this very carefully when we do it. Okay, I think I said all those things. You've probably seen this slide, but you know that the death from thalassemia has dropped dramatically with the implementation of these chelators and with the implementation of MRI. So there's a lot of hope out there. This is a study that Dr. Trickta mentioned. This is from Dr. Farmaki and Berdukas in Greece, where they normalized the liver iron. He showed you the data. They tried to get liver iron levels between 0.8 and about 1.2. This is totally normal range. In order to do that, you have to follow MRI very closely. You cannot do that with ferritin alone. But here, whoops, okay. This is pancreatic function. Glucose control before chelation, after chelation, much improved. Okay. Oops. Before chelation, 22% of the patients had normal glucose control. Didn't have diabetes. After chelation, 66% were better. Their diabetes was significantly improved. Now, if your pancreas is totally not working and you're completely insulin dependent, then iron control won't help you. But if you're on pills to help your diabetes, then about half of the patients can come off of those pills if their iron gets controlled. Similarly, testosterone replacement, half as many patients required testosterone replacement after controlling the iron, and half as many patients required thyroid replacement after controlling the iron. So their endocrine replacement is more tricky, but still there is some hope. This is one of my favorite slides. This is a Pakistani boy that came to us when he was about 14 years old. He was short. He was in heart failure. And we started him on continuous desferal, intravenous desferal. And this is his growth curve. You see the normal growth rate like this, okay? And then he grew, I mean, just amazing. He grew like a weed, okay? And his heart got better. So, heart problems are almost always reversible, but endocrine aren't. You have time to get your iron down, but you want to do it as fast as possible. If the cardiac T2 star is short, and especially if the contraction of your heart isn't normal, you are in great danger. This is an emergency. You need to get treated by somebody who knows how to treat you. Anytime you don't have chelators circulating, there's damage being done. And again, the same thing, just having chelator in your blood protects you. So if your ferritin is a little bit high and your iron's a little bit high today, don't be discouraged. Make sure you're taking the chelator all the time. That'll protect you. And you have some time to get the rest of the iron out. Now, just a couple of other points, and then I'll stop here. This is one of my patients, typical teenager. This is the ferritin. And see how much the ferritin levels are going up and down? The ferritin can change by 30% within a week. Not from iron, from inflammation and from other things. This is the liver iron. Whoops. This is the liver iron in red. So here she's about 20 years old, which is the time when many adolescents decide to start following their doctor's instructions. And you can see that her ferritin came down very nicely over the next few years, and her liver iron came down as well. She's then went to college. She's a college graduate. She's going to get married. All that wonderful stuff is happening for this young lady who's now in, I think, around 30, 32. But see her ferritin going up here from about 500 to almost 2,000. At the same time, her liver iron was dropping. So my biggest worry about this is that some doctor may say, based on the ferritin, that you're not doing what I said. You're not taking your medicine. This young lady was. Her liver iron was going down. And it's difficult, I mean, you know this, I only watch it, to keep up with medicines all your life. And I would think it would be very discouraging to have your doctor say, you're lying to me, basically. So I think that the message from here is ferritin can help, but they can be misleading. And you really need to follow the MRI at least probably every year. At our place, we get MRIs every year to year and a half, or when the ferritin change doesn't make sense to us. So ferritin is useful, but you can be misled. I already said all these things. Liver iron measurement by MRI is recommended periodically in all patients on chelation, and direct measurement of cardiac T2 star is very important because the liver iron does not predict what's going on in the heart. You've seen this curve many times. This is survival. Patients that are 100% compliant, that take their chelation all the time, survive. These are patients that don't chelate, and you can see this is the rest of the patients that are still surviving. They have a median survival that's very short, so survival is related to chelation. A couple of other things is that iron overload makes you lose vitamins. And so thiamine, which is an important vitamin to make your heart work well, half of the patients with iron overload lose thiamine. So multivitamins like thiamine are important to help you. Vitamin C is also important. There's a tendency not to give vitamin C because we're afraid that it's going to cause more heart damage. But becoming vitamin C deficient gives you bone disease and gives you other problems. So you need to have enough vitamin C, but not too much. Selenium, again, multivitamins will take care of this, but 75% of patients don't have enough selenium. Selenium is important to protect against iron. Okay? So the bottom line from this slide is that good nutrition, replacement of vitamins, mineral supplementation, these kinds of things are an adjunct. So, those are my thoughts about this. These are my opinions. I like this slide. Fernando's seen it multiple times. You should continue to seek the truth. Continue to ask questions, continue to learn. But it's very important to stay away from people who think they found the truth and think they know it all. Thank you very much.
Thank you very much, Dr. Thomas. Let's see if we have questions. Temos perguntas para o doutor?
Bom, parabéns pela apresentação. Qual seria o ideal de manter a quantidade de ferro na ferritina e também qual é o tempo? Você falou que é 1 ano, né, para fazer do coração e do pulmão e também do fígado. E qual seria o ideal, a gente que já está com uma idade avançada, manter uma relação de controle, não aquela que tira, mas que vai mantendo gradativamente uma quantidade pequena, né, para poder não acumular mais ferro.
Yeah, no, I understood. talks about having liver irons less than 5 to 7. Okay. In our practice, we don't do that. We try to keep the liver iron down between 1.5 and less than 1.5 to 2. The reason for that, but you need to understand that that's different than what many people recommend. But again, this is because I'm concerned about what's going to happen to you 40 years from now. 40 years from now. And I'm very worried about these second malignancies and these kinds of things that are related to iron. Okay? Yeah. So I would recommend keeping the iron that low. Now, the problem with that is you need to be able to monitor liver iron very carefully by MRI to do that safely. If you can't monitor it carefully, it would not be safe to try to do that with ferritin alone. Ferritin has some relationship to iron, but there is tremendous variability. So we have patients with ferritins of 100 and liver irons of 3. And we have patients with ferritins of 2,000 and liver irons of 3. Okay? So it's very difficult to have that precise control like that. When your liver iron gets down into the 2 range, 1.5 to 2 range, you are at risk for complications of too much chelation. And we start to reduce the dose of the chelator. And if we see the ferritin starting to go back up again, we check the MRI. And we adjust the dose. When your liver irons are that low, that means the patient is actually taking the chelator all the time, usually. And the dangers of cardiac iron and endocrine problems and so forth really are markedly reduced. So you have time, many months to a year, to make these corrections. You always need some chelator because you're always getting transfused. Does that answer your question?
Gostaria de saber qual é a quantia exata para tomar vitamina C. Porque quando eu era criança, mandaram eu tomar 20 gotas. Agora que eu estou mais velha, 10 gotas. Então, qual a quantia exata?
I don't know that there is an answer to that. We would say 100 to 200 milligrams of vitamin C a day for an adult. We actually measure those levels in our patients. Once a year we measure all the vitamin levels. And if the level is low, then we give a little bit more. You need to have some vitamin C. It can come through your diet. Vitamin C is a very important antioxidant. If you go into a bar with lots of smokers, the oxidant damage from the smoke that you inhale over an hour will lower your vitamin C level by 50%. So it's an important vitamin. I think that you should have fruits and vegetables in your diet, and the level should be checked from time to time. Yeah. Yeah. All right. Oh.
Mais alguma pergunta?
Eu gostaria de saber quem tem neutropenia devido ao deferiprone, quanto tempo qual é o intervalo que tem que ter para continuar tomando o deferiprone?
It depends. Maybe I'll let Dr. Trickta handle that question.
Então, tem duas coisas. Precisa ver se é o que nós médicos chamamos de neutropenia ou a granulocitose. Se for neutropenia, que é uma diminuição leve dos glóbulos brancos, daí você pode voltar a tomar o feriprox quando voltar ao número normal. E só ficar atento se não vai cair de novo. Então, se for neutropenia, que é uma diminuição leve, pode voltar a tomar, só ficar atento. Depois do mês, pode voltar. Se for a granulocitose, que é uma queda importante, daí se deve evitar tomar o feriprox, porque a chance de ter de novo uma queda ainda mais grave é muito grande.
I think that one of the most important things on Feriprox is if you're taking it and you have a fever, you need to stop it and see your doctor right away and have your white count checked.
É uma pergunta, não sei se convém, né? Mas na minha família eu tenho 2 irmãos que não têm talassemia. E eles já estão com o cabelo grisalho, já a partir de 50 anos já ficaram grisalhos. E eu, com 58 anos, ainda não fiquei, né? Eu vejo bastantes aqui que estão ainda cabelo preto, né? Não estão ainda grisalhos. Tem alguma coisa a ver com a quantidade de ferro?
Not to my knowledge, as a white-haired person. It is related to worry about your patients who have iron overload. Okay, thank you.